This symposium of Asian Arthroscopy Society, and our apologies for a little late to start the symposium, and without wasting much time, I straightway request the local coordinator, Dr. Arun Gupta, to start with the proceedings. Thank you.
Friends, a very warm of this is for the IOACON conducting Asian Arthroscopy Society in ECOS, and the gradually filling up, and I'll speak.
Lecture. The topic for the day is Applied Anatomy of the Knee, a Surgeon's Perspective. If you look at any single dimension of the knee, whether cartilage, everything on for whole day, and still the applied anatomy would not be over. But I'd like to focus on to most key aspects which we see and deal every day. We can divide this discussion in two parts, where an arthroscopy surgeon puts a scope inside and he sees various intra-articular structures like meniscus, ACL, PCL, patella, plica, and so many others. And we have to do the open surgeries for the multi-ligaments, fractures, and there comes the role of MCL, LCL, MPFL, anterior knee, posterior knee, medial and lateral, and so forth. I'll start with a small, simple, basic detail. That is the role of the tibial bony slope. This is much more discussed in the Arthroplasty Society. What is the role of tibial slope? Those who specifically keep themselves mostly to arthroscopy and not plasty. The tibial slope is about 5 to 10 degree inclined posteriorly. This is a normal slope, varies with the age, varies with the sex. But this has to be considered when we are doing the surgeries. Open wedge high tibial osteotomies can increase the slope, whereas the slope decreases in case of high tibial osteotomy. So if the patient has got a PCL injury where you do not want the PCL to sublux any more posteriorly, you can do the open wedge osteotomy and try the slope increases. So what happens, the tibia can come a little bit more forward. When tibia comes a little forward, so the posterior subluxation decreases. Whereas the same thing, if the patient has got a chronic ACL tear and you don't want to manage operatively by probably doing the ACL reconstruction, you can do the closed wedge osteotomy alone. However, at the moment, it is the open wedge HTO which is much more commonly done. You can control the slope. Actually, it is not always mandatory that it will end up with slope increasing. By putting the wedge plate, you can actually control the slope. You can make it neutral, you can actually increase it or in fact decrease it. Epicondylar axis, I would not go in much details. When we look at the condyles, this is an axis which is more important for the arthroplasty surgeon. This is just for the sake of mentioning, since we are discussing the anatomy. There are racial and sex differences in the condyles. The epicondylar axis is extremely important if you are placing your femoral components. I'll go back straight into the knee. When you put your scope, the first thing after clearing the inferior plica, what you see is the intercondylar notch. Normally, after you clear the inferior plica, that is a synovial fold which is attached from the ligamentum patellae, the retropatellar fat pad, to the superior part of the notch. There's a plica. The minute you clear the plica, you see a normal U-shape, inverted U-shape notch. Now this is normal inverted U-shape notch which is harboring the two cruciates. Whereas in case of a chronic ACL tear, many a times you would find that the notch has become very much narrowed, inverted V-shape. There was a time about 20 years back where the notch plasty, that is removing a part of the bone, was very commonly done. But then as the time progressed, people realized that it was not a necessary procedure. So routinely today, bony notch plasty, that is removal of the bone, is not done. However, if you find these kind of osteophytes, in growing into the notch, making it inverted V shape or a very narrow or a A-shaped notch, then you have to remove to prevent the further impingement after the ACL reconstruction. From the notch, once you finish your diagnostic scopy, one of the key structure what you observe is the meniscus. Now there are a couple of photographs which are not mine. I have borrowed it from Charlie Brown when we did the dissection of the knee together. He is my mentor in the knee. So this photograph is not mine, but we have done the dissection together. You see the two meniscus. Because they realized that the contract stresses on the articular cartilage tend to increase in direct proportion to the amount of meniscus removed. So the more the meniscus you remove, more is going to be the stress on articular cartilage, and this patient is much more prone for osteoarthritis in future. The results are fantastic. Patient is pain-free, locking-free in first few months to years. But if you keep following them for 5 years, 8 years, they come back to you, they say, my knee hurts. It is not normal. Even if you do meniscectomy, they do say everything is fine, but it does hurt. So meniscectomy, total or subtotal, removes protection, reduces stability. There will be a lot of stress on the cartilage. And total meniscectomy or subtotal meniscectomy should be condemned because it does lead to salvageable. If you see the meniscus, medial is much more fixed to the tibia, and it does not follow the femoral rotation. That's why it is more prone for injury, whereas lateral does follow rotation. It is connected to the femoral condyle through the meniscofemoral ligament. That's why it is much more free. The connections to the tibial plateau are much more loose. So with every movement of flexion, extension and rotation, lateral meniscus keeps on moving. It lateral is very, very important for congruency. We know that it's a convex or convex articulation. Second important thing is, whenever there is a movement in the joint, the medial meniscus, you will see again, medial meniscus moves inside. This is a centripetal movement. That's why with every movement of the knee, there can be a little bit more damage to the meniscus. So if you have to excise the meniscus, you have to excise a little bit more of medial meniscus, because with every movement it will tend to come more inside. Whereas lateral meniscus, you see, it moves outside, that is centrifugally. So even if there is a little bit torn part, you can leave the lateral meniscus because it won't come in contact too much. With every movement, the damage is more on the medial side. So that's why you can resect a little bit more. Otherwise, it will keep giving trouble to the patient. Third is the meniscal vascularity. We all know that the periphery is very vascular, known as red zone. It's an experiment by Arnoldsky, old experiment. We have three options. Either you resect the meniscus, repair the meniscus, or replace. Replace at the moment in India, we are not having it. So either you resect or you repair. So if you have a patient who has got a tear here, try repairing the meniscus, because this is a very vascular zone and meniscus does heal. And now these days, those who are performing more and more arthroscopy, they know that it heals. If it is here, you can take a call. If it's a younger patient, you can repair. An older patient, probably you can excise, and this should always be excised. Just done very recently, red zone tear. So in this case, I don't know about most of him, but a good arthroscopic surgeon or a knee surgeon should always refrain excising at least this kind of meniscus, and there's no excuse that I did not have the resources. If you do not have resources, please don't tackle the meniscal tears, because meniscal tear which is repairable should be repaired. First few months, maybe 1 or 2 years they do well, but after that the results deteriorate very badly. From the gross, we just go radial fibers and the circumferential fibers. It is the circumferential fibers which distributes the hoop stress. So any radial tear, the tear going from the inwards to outwards, is going to divide the circumferential fibers completely, and it is almost akin to total meniscectomy, because now hoop stress. And this principle is used in when we are doing the repair, whether to do the vertical suture repair or the horizontal suture repair. So meniscus is like, these circumferential fiber. When you put the horizontal suture, you see it is between the fibers, and with every cyclical loading there's a tendency that it can come out. So the repair can fail by sutures coming out. Whereas if you put the means taking all the bundles together, the repair will fail, but only fail by the failure of the suture material, not by the failure of meniscus. So this is the principle which is followed, taking this ultrastructure in consideration. So from the meniscus, we have understood that if it is repairable, please repair. Medial side you can resect a little bit more, lateral side always try to preserve more. Medial side is much more prone for injury as compared to lateral, and as far as suturing is concerned, the vertical suture configuration is much better than the, or much stronger than the horizontal. Cruciate ligaments, we all know, it provide anteroposterior stability. They are all extra-articular but intrasynovial. Intra-articular but extrasynovial, I'm sorry, it's wrongly written. And ACL is not attached on the tibial spine. ACL is attached between the two tibial spines, though it has got some insertion going up to the tibial spine, but ACL is not attached onto the tibial spine. The role of tibial spine is to give some amount of mediolateral stability. If you look at the cruciate ligaments, now there are two bundles. Anand sir is looking at me, there can be 3, 4, 5, but at the moment most of the cadaveric dissection, they say that it looks like a two grossly anatomic bundle, functionally also, but histologically they have not been able to prove that they are two different bundles. The ACL is about 38 millimeters on an average in length, 11 meter in width, 11 millimeter. But you see, it's not a ligament which is uniformly cylindrical from bottom to top. It shapes, it fans out on the top, it fans out bottom, and that is why the reconstruction of the cruciates have been a very tricky task, because you don't have any allograft or autograft which fans out like a dumbbell. Now, going to hit the important point. When we do the ACL reconstruction, we are trying to place it anatomically on the femur, anatomically on the tibia. Now, few years back it was the transtibial reconstruction which was more common. Now it is the anatomic reconstruction which is more common. And what does anatomic reconstruction means? Place the footprint of ACL on anatomically on femur and tibia. But that means you have to place from here to here. This is the medial wall of the lateral femoral condyle, and this ridge what you see is the lateral entocondylar ridge, and this vertical ridge what you see is the bifurcate ridge. Now the meaning is nothing is above the lateral entocondylar ridge. So ACL is never placed here. ACL is always placed in this area. Bifurcate ridge means in the front you have got the posterolateral bundle, and at the back it is the anteromedial bundle. So that's the entocondylar ridge, that's the bifurcate ridge. If one is doing the double bundle reconstruction, it is the AM bundle which is placed here, and it is the PL bundle which is placed here. But the anatomic ACL reconstruction, it is the center to center. You take the center of the lateral femoral wall here and center on the tibia. So this is the classical cadaveric study which was done by Yuki Kato. And there what he showed that the center to center reconstruction, if you are doing an anatomic reconstruction, it is the center on the footprint on the tibia and center of the footprint on the femur gives you the best possible anatomic and biomechanical stability. So how do we find the center? You can find the center with the help of a ruler, eyeballing, like somebody who's very experienced surgeon, he can do an eyeball, but for a newer surgeon you need to have a specific landmark, and that landmark is usually along the posterior border of the lateral meniscus, just adjacent to the medial tibial spine. Previously, we used to take about 6 mm anterior to PCL, which is not taken anymore. You can also take the help of a fluoroscopy. And on the femur, you can measure the wall from back to front, take the center point. If it is 18 mm or 20 mm, just take the center point and go a millimeter behind. That's where the center of the ACL lies. You can also use the fluoroscopy. Go to the PCL. It's again a dumbbell shaped ligament. You see it fans out from a large area. The footprint is very large. It gives a posterior stability, has got two bundles. And what is reconstructed is the AL bundle, because that's the one which gives the stability in flexion. And partial is PCL piers do heal as compared to the ACL. So if you see, it's a broad ligament. It fans out on a very large area. And this fact we have to take in consideration when we do the PCL reconstruction. If you take a PCL graft which is just 7.5 or 8 millimeter thick, it may do well probably with ACL, but it will not do well with PCL because it has already got too much of stress on it in form of a gravity while mobilization. So try taking a graft which is about 10 millimeters so that you can cover a huge footprint area. You see the footprint is huge. So, and if you do a single bundle, you are just doing the AL bundle. AL, that means it is shallow and high. When you are making a footprint on tibia, remember it is about 1.1 to 1.5 centimeter below the tibial plateau. If you're not very sure, you can always take the help of a fluoroscopy in the true lateral view. Keep your guide wire quite low, and that's where the help of the posterior anatomy comes. Meniscofemoral ligament. You will many a times find when you do the ACL reconstruction, you clean up this whole area, you may find this. Sometimes some people think it's just a synovial fold. It's not a synovial fold. It's actually the meniscofemoral ligament. It gives about 20 to 30% resistance for the posterior drawer. So do not excise the meniscofemoral ligament. Always try to preserve them. Medial plica, very frequently observed, unless it is pathological, should not be excised. If the patient had a clinical tenderness, when you were clinically examined, it's just adjacent over the medial femoral condyle, you can remove the medial femoral plica. The bony landmarks on medial side, now from the intra-articular, we have just moved out to the extra-articular. On the medial side, there is one bony prominence every orthopedic surgeon can feel, that is the medial epicondyle. MCL is not attached on the medial epicondyle. MCL is just behind and above. So it's about 3.5 millimeter proximal and 4.8 millimeter posterior. So remember, it is just behind that. And this is the adductor tubercle. So if you join a straight line between adductor tubercle to the medial epicondyle, the MPFL attachment is right in between. So if you can palpate, if you have opened that area, dissected it nicely, if you just palpate the adductor tubercle, palpate the medial epicondyle, in the center you would find the center of attachment of the MPFL. And this you can always confirm with the help of a fluoro. If you go into the layers from the first layer, go to the second layer, you will find the MCL, which is about 4.6 to 7.5 centimeter attached below the tibial plateau. And this is just behind the pes inserinus. Layer 3, you will find the deep MCL. Now, why the discussion of these layers? Because MCL, superficial MCL, gives the stability in valgus in 30 to 60 degree flexion. Whereas anything which is behind the MCL, that is the deep MCL, posterior oblique ligament, posterior medial capsule, it gives the stability in extension. Now, this fact is extremely important for the people who do a lot of knee work, because there's a lot of confusion going on what to do for MCL tears. And there is a statement which you will hear many a times in the conferences, MCL tear, do not do anything. That is only about isolated MCL tears. Low velocity, isolated MCL tears, probably in sports injury, you need not to do anything. Deep MCL, don't do anything. But we are talking about high velocity road traffic accidents which occur in India, or the accidents where the knee opens in extension. When the knee opens in extension, it means that the entire posterior-medial complex is gone, and such knees would never ever do well if you just leave it like that. That knee you need to repair, the entire complex. So deep MCL you need not to repair, you can just leave it, but posterior-medial complex and capsule is extremely important, and that keeps the knee valgus if posterior-medial capsule is torn. Isolated superficial MCL, only if it is avulsed from the tibia side, you can go and fix it. Medial patellofemoral ligament, I just told you that it's between the adductor tubercle and medial epicondyle. So you find the center point somewhere there, it is attached. Now there is a lot of discussion, is it isometric or is it anatomic? MPFL is a the current studies are showing that the anatomic reconstruction is as close to isometric. So probably in couple of years you will find that the anatomic MPFL is equally same as the isolated. So I'll skip off this. We don't need to. This is the recent study from Andrew Amis in AJSM published in 2012, where he has published that the most isometric point is almost same as the most anatomic point. Lateral side, you have got layer 1, 2 and 3, and we know that the LCL, this is the layer 3, which is the one of the most important layer. The LCL is attached onto the lateral epicondyle, just anterior and inferior is the popliteus tendon. Now all these structures, I would not go in detail, all these structures in general provide varus, external rotation and posterior stability. Medial side, those who take a lot of graft, remember when you make an incision here, one structure is at risk is the pes anserinus. If you are doing the MCL reconstruction, otherwise if you just elevate it, you can see the MCL below. Second structure which is at risk is the nerves. Now in my own hands, in the last 1 year, what we have found that the oblique incision is giving much less neural injuries as compared to the vertical incision. When I was making vertical incision, we had a lot of patient coming with the lot of paresthesia or hyperesthesia on the lateral aspect. So oblique incisions probably is helping in saving this nerve. And the lastly about the patella anatomy, there are a lot of facets on the patella on back side covered with the hyaline cartilage, and all these facets there the stress changes as the knee flexion changes. So you see as the flexion changes, it moves from inferior to superior and finally it comes to the odd facet. And this cartilage is always more prone for the chondromalacic changes. So these patients will come to you with the anterior knee pain and they say, it hurts only when I keep my knee bent, not in the straight, because this is more common over the median ridge and over the odd facet. Thank you.
How not to miss, and Dr. Amit Pankaj from Delhi is going to speak upon that.
A very good morning to you all. Thank you, Arun, and thanks, Dr. Ravi Gupta, for asking me to speak on this topic. This is a very basic talk because after the knee anatomy, my job has become quite easy because we want to evaluate these structures on clinical examination and then make up our mind what kind of injury the patient is having, and then we can plan our management. Okay, so clinical examination of the knee is the basic language of orthopedics, yet every surgeon speak my dialect, which might be different from yours and from other speakers. So the examination of the knee is divided into 4 general sections. General examination of the knee, which I will not go into detail. Then evaluation of meniscal pathology, then evaluation of ligaments, and evaluation of patellofemoral. We have a separate talk on patellofemoral disorders, so I'll again not dwell much on that. So it's basically the meniscal evaluation and ligaments evaluation. Anatomy has been very beautifully discussed by Pandey, so I'll not go into detail, but these are the structures that we want to evaluate on our clinical examination. And on the lateral side, these are the 3 basic structures that we want to evaluate. Okay, so one general point that I want to make here is while you are examining your patient, in palpation, try to develop a systematic manner in which you evaluate various points of tenderness. So start with the joint line, go to the medial and lateral side, then there are bony points that you need to palpate for tenderness. That's medial epicondyle, lateral epicondyle, proximal tibia, and tibial tuberosity, and the lateral side, on the lateral side, the head of the fibula. So always make sure that you palpate all these areas and make a note in your examination. Then patellar tap can be done to assess minimal or moderate effusion. Okay. Now coming to the evaluation of meniscus, meniscus can present to us either in acute conditions or in more commonly in chronic cases. So in acute presentation, it should be differentiated from MCL strain. And one must try to differentiate hemarthrosis versus effusion. As we know, meniscus produces effusion, and hemarthrosis is immediately after the injury, while in an isolated meniscal injury, the effusion, the swelling would come a little later. And patient might be having a false locking in acute injury. So acute assessment of middle meniscus or lateral meniscus is quite difficult, and thankfully these cases don't present that commonly in our practice. It's the late presentation of meniscus that we most commonly encounter with, and patients have, they present with two distinct categories: patients having history of locking and patients who don't have history of locking. And patients may give vague complaints like giving way, snaps, clicks, or even history of recurrent knee swelling after strenuous activity. So all these cases should be evaluated for meniscal pathology. The clinical assessment includes evaluating and assessing tenderness over the joint line, which is very sensitive test, might not be specific for meniscal pathology, but if a patient is having meniscal pathology, joint line. And then we try to produce the click by manipulative maneuvers, which have been variously described as McMurray's test that we have been taught from our undergraduate days. So the concept of McMurray's is we want to stress that torn portion of the medial meniscus by bringing that portion between the tibia and femur, and then we want to stress that. So as we know, the medial meniscus is commonly torn at the posterior horn, and the posterior horn is usually not under stress in normal flexion. So we want to do femur and then bring the knee from flexion to extension, and the patient will complain of pain by applying a varus stress. And for the lateral meniscus, we do the reverse, that is internal rotate the tibia and give valgus stress. Similarly, we can do Apple's test, in which the patient is made to lie prone, and you give compressive force, axial force along the tibia, and then try to rotate it internally and externally. In internal movement, if produces pain, that means there is lateral meniscal, and vice versa. So what is the sensitivity of clinical tests? For experienced clinician, the sensitivity of physical examination is about 70 to 90%. But there are about 30% of the cases of meniscal pathology that may be missed on clinical examination alone, and hence lies the importance of MRI for these cases. This is a test which has been described recently in JBJS, and it has been proven again by validity studies have been done. Tiselli's test. It is nothing but a dynamic reproduction of the stress that we do in McMurray's. So the patient is asked to stand on one leg, normal leg first, and then the abdominal side, and then patient is asked to turn to different sides. And by assessing these, the patient will complain of pain either on the medial side or lateral side, and you can make a diagnosis. Now coming to the evaluation of ligament injuries, few basic points. We always write in our examination notes 1 plus laxity, 2 plus or 3 plus. So what does that mean? 1 plus is 1 to 5 millimeters of abnormal laxity. 2 plus means the laxity is about 5 to 10 millimeters, and there is an end point which may be firm or which may be mushy. And 3 plus means that the translation is more than 10 millimeters and there is no end point. I always try to examine the normal side first, number one, to gain confidence of the patient, and number two, to establish basic ligamentous tightness in that particular patient, and try to assess the hard point. Now this is a basic slide taken from Campbell, which gives the interplay between the collaterals and the cruciates. If you look at this, the central figure, this is the neutral rotation. So collaterals are the knee into external rotation, the collaterals are still relaxed. But if you examine your knee in internal rotation, the collaterals, they tend to tighten, as well as there is intertwining of ACL and PCL. So meaning thereby, in case there is an ACL injury and you try to examine your anterior drawer or ACL Ligament test, this might not be positive. So try to examine your knee in three different degrees of rotation: external, neutral, as well as internal rotation. When do we say that it is positive? It is said to be positive in case it is more than 6 millimeters anterior translation, and must be checked in 3 different degrees of rotation. Internal rotation may reduce translation because of taut PCL. Now again, a very important point that you must ensure before you start examining for ACL or PCL injuries, try to establish the normal step off between the tibia and the distal femur. And as you would appreciate, that tibia is almost 1 to 1.5 centimeters anterior to the distalmost portion of the femur. And in case it is sagged behind, always make sure that it is not the PCL or against the ACL injury, because sometimes for the initial part of our practice, we start misdiagnosing PCL injuries as ACL injuries. I'm sorry, this video is not working. So, so anterior drawer test is done at 90 degrees of knee flexion, and always make sure that the hamstrings are relaxed, because if the hamstrings are not relaxed, you are likely to get a falsely negative anterior drawer test. And always try to stabilize the distal part of the limb either with an assistant or sitting onto the foot of the patient, and try to examine in 3 different degrees of knee rotation. Now, if you try to examine the knee in 90 degrees of flexion, what happens is because of the posterior horn of medial meniscus, sometimes you are not able to bring the tibia forward despite the ACL being not present. So to counter that effect, you try to take the knee into extension and then examine this again. That forms the basis of Lachman's test, and it is said to be the best acute test, because in acute conditions, you can't flex the knee because of the pain to 90 degrees. And a Lachman's test is done at about 30 degrees of knee flexion, and then you try to hold the distal thigh with one hand, and with the other hand, you try to give anterior force. And abnormal laxity can be appreciated by comparing with the abnormal side. Now, what happens in case you encounter a patient who is the thigh is very bulky? Then there are a couple of modifications that have been described, which you can do in your clinical practice to assess the Lachman's test. You can make the patient lie prone. By doing that, the thigh is stabilized by the couch, and you can use both your hands to give anterior push. So that I find quite helpful in my clinical practice while evaluating wrestlers and heavy patients. Now, coming to the very specific test for ACL, that is the pivot shift test. Pivot shift test is done with the knee in extension. You try to give a valgus force and internal rotation of the tibia, and then the tibia would sublux anterolaterally. And in case you try to flex it further, the tibia will reduce spontaneously. So this is the basis of pivot shift test, and this is a very specific test for ACL. Let me see if this video works. I'm sorry for this. Coming to PCL, PCL, as we know, is the primary stabilizer of the knee against posterior movement, and then it is the secondary restraint against external rotation as well. So there are subtle signs of PCL injury that you might see in your patient, like a healed scar on the anterior part of the tibia, which tells you that the mechanism of injury would have been a dashboard injury, and you always think on the lines of PCL. Now again, to evaluate your knee for the PCL, try to establish the base, the normal step off between the distal femur and the proximal tibia. And as I said, it is about 1 to 1.5 centimeters. In case this relationship is not maintained, always suspect a PCL injury. Now, it is always beneficial to see both the knees from profile, and you can appreciate a subtle posterior sag much better in that fashion. And you can even accentuate the posterior sag by making use of the gravity. Take both the knees, take hold of the both bilateral feet and take into 90 degrees of flexion, and you can evaluate better. Now, posterior drawer test can be grade 1, 2, or 3. Grade 1 posterior drawer is when the tibia is still in front of the femur, but it is not normal. And grade 2 means both tibia and femur, they come to lie at the same position. And grade 3 means the tibia subluxes even further backwards. So grade 3 posterior drawer means the patient is having much severe injury, much more than an isolated PCL injury. So another test that is done for PCL injury is active quadriceps test. Try to stabilize the distal part of the leg and ask the patient to actively try to extend the knee. And the posteriorly subluxed tibia will come forward, and you can appreciate that. Now coming to MCL, MCL is primary medial stabilizer against valgus force, and secondarily it stabilizes the tibia against external rotation. So always try to assess medial sided injuries in 0 degrees and 30 degrees. As Vivek has rightly pointed out, in case the test is positive in 0 degrees, the injury is much more severe than isolated MCL injury. And in case it is only positive at 30 degrees of knee flexion, then you can safely say that it is only a MCL injury. A test that is positive at 0 degrees and 30 degrees, that means the injury is very severe. Now coming to lateral side, always examine the knee for the varus instability in 30 degrees as well as in 0 degrees. Isolated injuries to LCLs are very uncommon. In case the test is positive only at 30 degrees, that you can say that LCL is injured. In case the test is positive at 0 degrees, that means the injury is much more severe. I'm sorry with these videos. The videos somehow are not running. Coming to posterolateral corner. posterolateral corner is one area which we often forget to examine during our routine clinical examination. So PLC is a structure which resists external rotation of the tibia, and secondarily it resists posterior translation. So the test that is done to assess the PLC is dial test, which assesses the knee for posterolateral rotatory instability, and should be done at about 30 and 90 degrees of knee flexion. It can be done in two ways. You can have your assistant holding the thighs of the patient and the knee is at 30 degrees. You try to give external rotation, and then you can look for the thigh foot angle. In case there is any discrepancy, then the dial test is positive. And this test can be done at with the patient lying prone, and you take the knee from 30 degrees to 90 degrees, and at the same time give external rotation stress and look for thigh foot angle and any discrepancy. If you look at the left side, so the patient has an abnormal thigh foot angle on this side, so making you, so that's the left side is abnormal. And in chronic cases of posterolateral corner injuries, the patient walks with very peculiar gait of varus thrust. So that also gives a hint of chronic posterolateral injury. Another test that can be done to evaluate posterolateral corner injury in acute conditions is a recurvatum test. Catch hold of the thigh, distal limb of the patient with the holding the great toes, and then you can see the recurvatum of the right side. Reverse pivot shift is the reverse of the pivot shift that is done to evaluate the posterolateral corner. So flex knee with a valgus and external rotation stress, the posterolateral tibia subluxes in the posterolateral direction, and then as you extend, the tibia comes back. So abnormal external rotation and posterior translation, that means the posterolateral corner injury is there. I think PFJ, we have a separate talk on PFJ injuries, so I'll not go into the evaluation of PFJ. So with that, I'd like to thank you, and in case there are any questions, please ask on that.
We'll have discussion at the end of the
Okay. Thank you.
We are running slightly behind the schedule.
Morning, everyone. First of all, I thank the Asian Arthroscopy Society and the organizers of the association for giving me an opportunity to speak in this forum. Now, imaging of the knee is very essential. Now, we all can read plain X-rays, so we'll just rush through it. So these are the AP and lateral X-rays which we usually do, and confused with any injury like this sesamoid bones which are present on the posterolateral aspect or by. Now one thing is that many a times we advise merchant view for patellofemoral problems. You should make sure that the knee is not in 90 degree of flexion, because in that condition the patella automatically centers over the cochlea. Okay? So you must always advise that it should be done in 30 to 45 degree of flexion. So that is mainly done for patellofemoral problems, and that we'll discuss during the patellofemoral session. Patellar dislocation like this can be easily diagnosed, and sometimes you have this type of X-rays where you should see that there is not a single straight line, but there are double line. So this should give you a suspicion that there is a fracture, and that should be confirmed by CT scan. Dislocations like this can be diagnosed clinically, and there are some subtle indicators of ligamentous injuries around the knee on plain X-rays, like this tibial spine eversion, which you can properly see on notch view, or you can have this type of Sagon fracture, which is basically a flake fracture from the lateral aspect of the tibial condyle. So this indicates ACL injury. Now, if you have a fracture, then I think a CT scan is a must, because Sometimes these fractures cannot be diagnosed properly on plain X-rays, especially posteromedial and posterolateral fragments, which will then decide the approach for the fracture management. So in these cases, CT scan should be done, and they can give you the proper anatomy and the fracture pattern, which will help you in deciding the management plan. Now comes the MRI. In an injured knee, MRI, in a ligamentous injured knee, the MRI is now perhaps the most commonly used diagnostic modality. The orthopedic surgeon, we must know how to read MRI. So these are basically done in three planes: your sagittal cuts, the coronal cuts, and the axial cuts. Now in sagittal cuts, mainly we see the cruciates, the meniscus, and the extensor mechanism. The collaterals and the meniscus. Whereas the axial cuts are mainly important for patellofemoral problems. So these are the structures which we can diagnose, which we can see on MRI. The normal meniscus appears as a black structure. In the periphery, it appears like this bow tie configuration, and then as we go towards the center, then it separates into triangle pieces. Now they always appear as black structures because these are made up of fibrocartilage. So fibrocartilage doesn't have fluid content, very less fluid content. That's why. Now, if you see anything white within this fibrocartilaginous structures, then that means that there is a degeneration. So this is a degeneration. When this degeneration is within the confines of this meniscus boundary, that is not a tear. That is degeneration. So many a times you'll be seeing that it's grade 1 or grade 2 degeneration. But actually the meniscus, if you do arthroscopy, you will find it intact. It's only when this degeneration extends out of the margin of the meniscus, then it becomes a tear. So that becomes a grade 3 degeneration. So that is a meniscus tear. So that's how you diagnose a meniscal tear on a MRI. So these are the three basic types of meniscus tear. We won't go into the anatomy of the tears. So here you can see that this tear is extending from superior to inferior and is dividing the meniscus into outer and inner part. So this corresponds to this type of tear, the longitudinal tear. Similarly, you can have a radial tear, or you can have a flap tear, the horizontal tear. So horizontal tear divides the meniscus into superior half and inner half. So here you can see this high intensity signal which is coming at the tip of the meniscus. So that is dividing the meniscus into superior part and inferior part. So that is a horizontal tear. And then you have this bucket handle tear. So what happens in bucket handle tear? The inner part is dislodged into the notch. So then this part comes to lie in front of the PCL. So this appears as a double PCL sign. So that indicates that there is a meniscal tear, and which is probably a bucket handle tear. Also you can see this portion. So this is the part of the meniscus which has been dislodged from here, the torn meniscus, and is lying here in the notch area. So again, in order to diagnose a meniscal tear on MRI, you should have this white signal within the black meniscus which is extending outside the boundary of the meniscus, and there is also alteration in the shape of the meniscus. So here you can see that it's a triangular structure, whereas here it's a blunt structure. So a part of it has gone somewhere. So that is also indicator that it can be a meniscus tear. The normal ACL appears as a gray structure going from tibia to femur, and it is either parallel to this Blumenset line or is more vertical towards it. Now if you can't see any ACL here, or if you see a ACL but it is lying flat, that means that it's a meniscus, it's a ACL tear. The ACL is non-functioning. So many times the cuts are not taken into account. Appreciate. In that cases, there are some secondary signs which will indicate that probably there is a meniscus. So these are the indirect signs. So what happens when there is a ACL tear? There is pivoting of the femur over tibia. So this leads to this bone bruising in the posterolateral part of the tibia and posterolateral part of the femur. So that is a direct. The PCL has subluxated forward, and then it appears a question time. So of the also in orange that doesn't break, but it's avulsed from the tibial condyle. So this avulsion of tibial condyle is also a sign of non-functioning ACL. Now PCL appears like a black structure, and that is the normal trajectory of ACL. So if you see any white thing within the meniscus, that means there is discontinuity of the PCL, or you can have avulsion from the tibial side or femoral side. Now collaterals are usually appreciated on the cornal cuts. So here you can see this is the MCL, which is a black structure. There is no space in the condyles. If you find some space, if you find that it's lifted from there, that means there is some injury, either it's a sprain or a tear. Lateral collaterals are difficult to here. So they don't one cut. So you have to appreciate it on different. Contrast like these, you can apart from normal condyle is surrounded by fluid. So that is a sign of desicance. Other things which you can see are meniscal cysts. They are quite evident, or many a times you see this ganglion cyst in relation to ACL or mucoid degeneration of the ACL. Discoid meniscus, as you bow tie configuration, meniscus to anterior configuration meniscus. It has not fitted into two horns. Diagnose extension mechanism tear on MRI. Here you can see there is rupture of the quadriceps tendon from the superior pole of the patella. Here you can see rupture of the patellar tendon from the inferior pole of the patella, or avulsion from the tibial tibia. Diagnosed clinically, but you can just substantiate it by MRI. So your diagnosis is mainly clinical, but in order to confirm it, you have to do these MRIs. And if you know how to read MRI, then you can confirm your diagnosis. Thank you.
Again, a very good morning. The theme from the coordinator, basic topic called knee hemarthrosis, what, when, and how.
Hemarthrosis literally means blood into the joint. And what are the causes? They are briefly categorized in 2 or 3 categories, that is traumatic, non-traumatic, and miscellaneous. And according to the Sports Trauma Research Center from Finland, the main cause of any knee hemarthrosis, that is about 50% of cases, you are sure without going into the history that it is because of anterior cruciate ligament tear. Then there are others like patellar dislocations, at times MCL tears, meniscal tears, PCL tears, and very less osteochondral fractures. The history to the knee hemarthrosis, even before touching the patient, gives you a clue that if it's a high velocity injury, the likelihood is fracture. If there is a audible pop or palpable or feelable pop twisting or giving way, it could be a cruciate ligament, that is ACL injury. Blow from the front, a posterior cruciate ligament could be at risk. And if the injury is occurred while simple squatting, kneeling, and it presented with locking, it could be because of meniscal tear. Then, if the fulling or the effusion in the knee joint is accompanied by fevers, chills, and has a history of IV drug abuse, it could be infection. And at times, when the rare causes like presented with night pain, unexplained weight loss, it could be because of any malignant tumor or a benign tumor in the bone, in the joint. The timing is also important for the knee to fill up. If it is immediate, again, fracture comes in your mind. Within 4 to 5 hours, cruciate ligament injury. And after that, it could be a meniscal injury, that is the late hemarthrosis. At times, beware of that thing that at times the injury could be more severe when the capsular disruptment has happened, and that leads to more severe injury, and the fluid could not accumulate inside and it has gone out, which leads to such sort of ecchymosis. That means the injury is more severe. If it is contained, the injury is less severe. Then non-traumatic causes, there are, just to enumerate, Charcot's joint, hemophilia, other coagulopathies, patient on aspirin or other blood thinners, pigmented villonodular synovitis, tumors, scurvy, and at times aneurysms and other arteriovenous malformations. Then comes to the investigation. That is, one is aspiration in your OPD, X-rays and MRI, Dr. Shekhar has already dealt with. So aspiration should be done with full aseptic measures. The OR environment is not required at all. Some people say that aspiration has to be done in an operation theater, but you exercise a good aseptic precaution you can do in your OPD. So it's a little technique in which the aspiration, how is to be done. It is to be prepared by spirit or sterilium, and then you can paint it with betadine or chlorhexidine. Then there are various ways to aspirate, but the most common I have seen, most of the orthopedic surgeons aspirate in from superolateral part of the superolateral pouch, inject some xylocaine or bupivacaine to numb that part of the skin. And then put a wide bore needle, something like 18 gauge or 16 gauge, into the joint gently, targeting anteromedially, and aspirate with at least 10 cc syringe, not 5 cc, not 50 cc, 10 cc syringe to initially create an optimal vacuum. If the vacuum is high, the synovium comes and blocks the needle, and if the vacuum is low, then an old hematoma won't come into the needle. And then put a kidney tray to collect the residual blood and observe that blood, which has got certain leading clues to the joint. For ease, initially I recommend to many of the postgraduates that use 18 gauge IV cannula rather than the 18 gauge needle, because you have got a needle stillate with you which can dislodge the debris which have clogged the needle or synovium. By sharp obturator needle you can dislodge it. Observe the fluid. If the fluid is initially clear, followed by blood, it means you have done a traumatic tap, something like a spinal. When your anesthetist gives a spinal, when the fluid is initially clear and then comes blood, that means you have done some trauma to any vein or something, that means the blood is coming out. If it is only blood, pure blood, then it means it's pathognomic of a ligament injury or a meniscal tear. And if it is mixed with fat droplets, that means there is somewhere breach in the chondral area, that means the bone marrow has come and mixed with the blood and leading to the supernatant fat globules on the kidney tray. So aspiration could be divided into two. First is diagnostic, when the diagnosis is not sure, and if you are suspecting some sort of infection. And it could be therapeutic for symptomatic relief in very tense hemarthrosis. The patient is in agony, but at this point of time, I just compare it with the hip hematoma. Hip hematoma has to be decompressed as soon as possible because of the risk of avascular necrosis. No such risk is here in the knee joint. to decompress as soon as possible, decompress at your ease and in the patient symptomatology. And at times when there is severe pain because of that hemarthrosis, the patient is not allowing you to examine the knee properly. And in that case, when you decompress it, it improves your examination accuracy, and it confirms the severity of injury, as I've already mentioned, that if it contains flat globules, that means there is some concomitant fracture. There is some rules to get the X-ray done in an acutely injured knee, not fractures. If the patient's age is 55 years or older, there is a tenderness at the head of the fibula, looking for the Seagon sign, isolated tenderness of patella, inability to flex more than 90 degrees, inability to bear weight both immediately and in emergency department, that this patient not able to walk about 4 or 5 steps. So in investigation, what you have to look for is some sort of Seagon sign, which is pathognomic of ACL injury or ACL avulsion from the tibial side. In MRI, again, ACL tear, some subluxation or dislocation of patella, or medial patellofemoral ligament disruption. Then what is the immediate treatment? Seal the needle prick with iodine or whatever, and then the RICE therapy is to be instituted as soon as possible. For further treatment, symptomatic and supportive treatment is to be given. No role of antibiotic. I've seen many people writing antibiotics after aspiration, even in diabetic patients. There's no role, because if you've exercised good aseptic measures while aspirating, there's no role of antibiotic. Start rehabilitation as per the pathology. What happens if the hemarthrosis is presented to you late and if it is there? So the hemorrhage leads to synovitis and hemocysteine deposition in the synovium, which leads to eventually synovial hypertrophy, and that hypertrophy, like in rheumatoid arthritis, leads to chondral damage and eventually arthritis. So a complete history, a thorough physical examination, and a judicious laboratory radiological testing can simply evaluate the knee hemarthrosis. Aspiration should be performed when the etiology of the effusion is unclear, when infection is suspected, or to provide patient comfort and facilitate physical examination. Thank you very much. A very important topic called acute dislocation of the knee joint, which comes now and there in any orthopedic outdoor. Dr. Vivek Pandey, please.